Good evening, everyone, to another session of CME in CGHS. Today's topic is on fundamentals of electrocardiography. ECG, as an investigation, has been used for decades for diagnosis and management of physiological, structural problems of heart and systemic problems like electrolyte imbalance and drug toxicities. In terms of statistics, every test has its sensitivity and specificity, the consequent positive predictive value and negative predictive value. In case of ECG, for myocardial infarction, the sensitivity varies from 30 to 70%, and specificity varies from 70 to 100%. In case of the sensitivity of conventional ECG as a predictive tool for coronary artery disease and LVH is too low to be a practical screening tool. The positive predictive value for of ECG is too low for it to be a screening tool for left ventricular systolic dysfunction. But a conventional ECG has an excellent negative predictive value when normal in case of left ventricular systolic dysfunction. So I wanted to give a statistical perspective to the talk before the talk begins, as the clinical scenario hugely impacts the ECG interpretation. In short, there is no uh, replacement of a good history and examination, and isolated ECG interpretation should be avoided. Now I hand over the mic to Dr. Amit Agarwal, who is a senior physician at ABVIMS Dr. RML Hospital, New Delhi, for the talk.
Thank you, Dr. Mudit, for the introduction. Today, we will be dealing with the very basic fundamentals of electrocardiography. Most of the clinicians are alarmed by the mere fact of interpretation of an ECG in clinical practice because the books on electrocardiography seem to possess several disadvantages for the beginner. The introductory chapters on electrophysiology are so intricate and long-winded that troubled of what is the basic electrophysiology, the vector cardiography, uh, the interpretation of simple ECG, so that after today's talk, we are able to assess that what is a normal ECG and what could be the broad abnormalities, anomalies that we see in a usual day-to-day practice. Look, the interpretation of an ECG changes with the perspective of the clinicians. For example, with me also, if I'm working in a dispensary or a wellness center and I need to assess somebody's ECG, my first priority will be to see whether there is something, some sort of an emergency in the ECG, for which I need to refer the patient to an emergency department of some hospital, or it is something benign which can be dealt with in a routine follow-up on the OPD basis itself. In a hospital, the perspective changes, and subsequently in the ICU, we are much more uh, quite microscopic assessment and interpretation of the ECG to assess drug toxicities, ischemia, cardiomyopathy. All these things are assessed on the basis of ECG and confirmed with the echocardiogram. So, what is an ECG? The electrocardiogram is the tracing of heart's electrical activity. It is as simple as that in a single sentence. Uh, how it was? Yeah, thank you. Who invented the mechanism, method of detecting and tracing the electrocardiogram? It was almost 100 years ago by William Entwerpen, who was a Dutch physicist born in Indonesia. And he was awarded the Nobel Prize also in the field of physiology and medicine in 1924. He developed a galvanometer in which the cardiac tracings of dogs and cats' heart was done out, which was later done on human beings as well. So, starting with the basic cardiac electrophysiology, we need to know that from where the cardiac impulse, the impulse of depolarization generates, where it traverses and where it reaches. This is the fundamental knowledge on the basis of which the electrocardiography is based. We all know that the pacemaker, the natural pacemaker of the heart, is the SA node, the sinoatrial node, from where the cardiac impulse is generated in a normal individual. That cardiac impulse travels across the atria to reach the AV node, the atrioventricular node, from where it is further carried along the interventricular septum in the bundle of His. Subsequently, to the bundle splits into the right fascicular branch and the left fascicular branch, leading to the Purkinje fibers, which innervate the ventricular myocardium, causing depolarization. Uh, the ECG tracing alongside the traversing of the cardiac impulse is also depicted simultaneously. There we can see the contraction, the depolarization of the atria from the SA node is depicted as a P wave. Later on, the depolarization of the ventricle when the impulse reaches from later on through the Purkinje fibers is in the QRS format, and then there after the repolarization is depicted in the form of the T waves. What are the types of the leads that are used in the normal ECG? Usually we use 10 electrodes, which are basically 6 chest leads and 4 limb leads. The 4 limb leads Yeah, the types are coronal, the limb leads which depict the cardiac impulse in the coronal plane. These leads are either bipolar or unipolar. The bipolar leads are lead 1, 2, and 3, and the unipolar leads are AVL, AVR, and AVF. The AVL, AVR, and AVF are usually the composite leads which derive their data from the bipolar leads, and they depict it in the form of the ECG tracing. In the transverse plane, there are the chest leads, which are usually from V1 to V6. The placements of these leads we will be discussing later. The vector cardiography, the tracings of the ECG that we see on the electrocardiograph is important to know, because the electrical vector is oriented towards the exploring electrode and therefore causes a positive deflection if the impulse is traveling towards the positive electrode. And if the cardiac impulse is moving away from the positive electrode, then the electrical vector is depicted in the form of a negative deflection. For example, in a transverse plane, we can see here that the chest leads from V1 to V6 depict a smaller uh, V1 lead, because the impulse is most in the direction of the V4 to V6 direction. And there is a progression of the R waves from a smaller R to a larger R amplitude when they reach the V5, V6. So this will be useful in the understanding of the ECG in the later on stage. The electrode placement is important to know. There are 4 limb electrodes as we discussed. The right arm, the left leg, and there is a dummy electrode in the right leg. The lead 1 is basically constituted by a negative electrode on the right arm and the positive electrode in the left arm. Lead 2 is consisting of a negative electrode in the right arm and the positive electrode in the left leg. And lead 3 is consisting of a negative electrode in the left arm and the positive electrode in the left leg. The right leg electrode is a dummy electrode. And likewise, there are 6 chest electrodes from V1 to V6. The V1 electrode is placed on the 4th intercostal space to the right of the sternum. The V2 is fourth intercostal space immediately to the left of the sternum. V3 is placed directly between V2 and V4 when V4 is placed in the fifth intercostal space at mid-clavicular line. V5 in the left anterior axillary line in level with V4, and V6 in level with V5 in the left mid axillary line. When we need to check for right-sided chest leads, the V4R is placed in the fifth intercostal space in the right mid-clavicular line. Subsequently, in cases of posterior wall MI, we have methods to detect it in the standard chest leads, but we can go on for a V7, V8, V9 posteriorly in the back also. Here we can see that the lead 1, lead 2, lead 3 are the bipolar leads, and they are the primary leads, and AVR, AVL, and AVF are composite leads which derive their data from lead 1, 2, and 3. So all these electrodes basically depict some area of the myocardium which it represents. We saw earlier on that in this slide that right atria, right ventricle, the interventricular septum, the left ventricle, these are all depicted in the horizontal plane, in the transverse plane by chest leads, and likewise in the horizontal frame, we can these areas of myocardium are depicted by the lead 1, 2, and 3, which are the limb leads. The elements of the ECG, the P wave is depicting the atrial depolarization, the QRS complex depicting the ventricular depolarization, and the T wave is depicting the repolarization of the ventricles. Okay. This slide depicts the duration of the PR, the QRS duration, the QT duration in the normal subjects. The PR interval is usually between 0.12 to 2.20. The QRS duration, the upper limit is 0.12 seconds, and the QT interval is between 0.35 to 0.45 in males and 0.36 to 0.46 in females. In some cases, we get U waves also. We will be discussing it later. The RR interval, that is the distance between the two consecutive R waves, is also important in order to calculate the rate of the cardiac cycle. As we said, the heart rate is calculated on the ECG tracing, provided the rhythm is regular by 300 divided by RR interval, where the RR interval is calculated by counting the number of large squares between the two consecutive R waves. If we are calculating the smaller squares, then we have to use 1500 divided by the RR interval. This number of 300 and 1500 is reached by using the usual running speed of the ECG machine, which is usually kept at 25 millimeter per second. Each small square is 1 millimeter in width. So by calculating 25 millimeter into 60 seconds, we get almost 1500. One large square consists of 5 smaller squares. So the RR interval is used by calculating the number of consecutive R waves and the large squares between the two, and then dividing this by 300. From 300, we get the usual heart rate. This is the example. Now, here there are 3 large squares between the two RR complexes. So 300 divided by 3, we get 100 beats per minute. There are 2 larger squares, 300 divided by 2, we get 150 beats per minute. 5 large squares between two RR complexes, we get 300 divided by 5, 60 beats per minute. So this is how we get the rate. And if we are using smaller squares, then we divide the smaller squares from 1500, 5 small squares between RR, we get 1500 divided by 5, we get 300 beats per minute. Likewise, 1500 divided by 15, 3 larger squares, or 15 smaller squares, 1500 divided by 1500 beats per minute. So these are different ways in which we can calculate the heart rate. Rhythm. Even before knowing the rate, we should know the rhythm, whether it is a sinus rhythm, it is sinus arrhythmia, or supraventricular or ventricular rhythm, because till the time we are sure that there is sinus rhythm, the above method is not very foolproof to see the heart rate. In cases of AF, for example, where RR intervals are not constant, there are they are irregular, then we calculate 10 RR intervals, and then we get to we decide calculate how much is the duration in which those 10 RR complexes are there, and then we calculate the heart rate, or otherwise in 10 seconds we calculate how many RR intervals, RR waves are there, and then we calculate the uh, heart rate from there. What is a sinus rhythm? When cardiac cycle originates from sinus node, uh, and every QRS complex is preceded by a P wave, then we call it a sinus rhythm. Um, Although the reverse is not true. There could be QRS complexes which are not preceded by a P wave. The origin of a cardiac impulse from this SA node in the form of a normal P wave is the most important thing to find out whether it is a sinus rhythm or not. Sinus arrhythmia is there. There is a change in the heart rate depending upon the phase of respiration. During inspiration, the cardiac cycle length shortens. The mechanism behind it is that during inspiration, the intrathoracic pressure decreases, which increases the venous return, leading to the increased stretch of the right atria, leading to brain bridge reflex, causing impulse to the brain stem, which increases the heart rate, leading to a shortening of the cardiac cycle. The reverse happens during expiration. So sinus arrhythmia is that the QRS complex, the P waves, they are regularly in relation to each other. Each QRS complex is following the P wave, but the RR complexes may be irregular slightly. But uh, the composition of the PQRST, it is not disturbed. This is also seen in people who are on digitalis. Then there is sinus bradycardia when heart rate is less than 60 beats per minute, or sinus tachycardia, which is the heart rate is more than 100 beats per minute. These are some of the basic rhythm disturbances. We can see the normal rhythm in the first graphic. Then there are premature ventricular beats. There is paroxysmal supraventricular tachycardia, in which we can usually see we are not seeing the P waves, and it is a narrow QRS complex tachycardia. Then there is atrial fibrillation, where RR complexes are irregular, and usually the P waves are not seen. In flutter with the variable AV conduction, there is sawtooth pattern of the P waves, and the RR intervals are based on the variable AV conduction. There could be 2:1, there could be 3:1. That conduction rate decides the RR interval. Uh, in atrial flutter with 1:1 AV conduction, usually after every P there is a R, so that is 1:1. And in monomorphic VT, there is a wide complex QRS complex tachycardia, which is different, that we will be discussing later. The classification of rhythm based on rates. If the origin of the rhythm is from SA node, the sinus node, if the rate is less than 60 beats per minute, then it is sinus bradycardia. The normal sinus rhythm, normal rate is 60 to 100 beats per minute. More than 100 is sinus tachycardia. If the focus of the impulse generation is from the atria, then if the typical rate is less than 100 beat per minute, then it is a wandering atrial pacemaker. And if the rate is more than equal to 100, then it is multifocal atrial tachycardia. If the origin of the impulse is from the AV junction, and the typical rate is less than 60 beat per minute, it is junctional escape rhythm. with rates between 60 to 100, it is accelerated idioventricular or accelerated junctional rhythm, basically. And uh, more than 100 is axial tachycardia. When the ventricles are focused, critical rate less than 40, because that is the intrinsic rate of the AV node or the ventricle. The less than 40 is ventricular escape rhythm. Between 40 to 100, accelerated ventricular rhythm, and more than 100 is usually ventricular tachycardia. The axis. The axis is very important because it is the net or average direction of the cardiac impulse or wave of depolarization. Normal axis is between 30 degree to 90 degree, minus 30 to plus 90. This is depicted in the diagram which is shown there. We can see the usual axis we can calculate from lead 1 and APF. Lead 1 is, if we trace a graph, uh, then we get the x-axis as lead 1 and the negative y as AVF, because these are the usual lead placements, 0 degree and 90 degree. And we plot the axis by the net positive or negative deflection of the QRS complex. If there is a net positive deflection of the QRS complex in lead 1, then we plot it to the right side on 1. Uh, and if it is negative in AVF, for example, then we plot it in the lower southern quadrant, which will give us the normal axis between AVL and AVF. If both the QRS complexes are positive in 1 and AVF, even then we will get it here. If the right axis, if the uh, QRS complex is showing a net negative deflection in 1, then it is plotted on the left side. And if it is positive in the AVF, it is downwards, it will be right axis deviation. And if both are negative, it is plotted in the northern and the left. It is a northwest axis, which we call as the extreme right axis deviation. So we can we see it in this small graphic in the leads in 1 AVF, which are given in the diagram. uh, 1 positive, AVF negative in the first quadrant between 0 to 90 degree. If it is falling between minus 30 and 0, then it is normal. Both positive, 1 and AVF in the second quadrant between 0 to 90 degree normal axis. 1 negative, AVF positive in the third quadrant between 90 to 180 degree right axis deviation. Both negative between 180 and minus 90, or 180 or 270, you can call it as extreme axis. The causes of right axis deviation usually are right ventricular hypertrophy, lateral wall MI, left posterior hemiblock, pre-excitation syndromes in the form of WPW, pulmonary embolism, and ventricular tachycardia. Uh, we need to know that in these conditions, the pathology causes the impulse transmission towards the right axis, or not in the usual lead to direction, which is a usual pathway of the impulse transmission, but towards the other side, towards the right side. Uh, it can happen in either of the conditions. Likewise, the left axis deviation between minus 30 to minus 90 happens in left ventricular hypertrophy, left anterior hemiblock, pre-excitation in type B WPW, or inferior wall MI. For example, in inferior wall MI, the myocardium in the inferior wall is necrosed, it is infarcted. So the impulse transmission will happen in the upward direction, the left axis. Or likewise, in lateral wall, the lateral wall of the myocardium towards lead AVL and 1 will be necrosed or infarcted. So the impulse transmission, the net impulse transmission, will be towards the right side, which will lead to right axis deviation. Pre-excitation syndromes, WPW syndrome, can have both the axis depending upon type A and type B. In type A WPW, there is RBB pattern, short PR, and delta waves. The RBB leads to right axis deviation, and in type B, there is LBB, depending upon the location of the accessory pathway leading to left axis deviation. The axis, this is a tracing on the ECG. We can see here that there is no negative impulse and there is a net positive deflection of the QRS complex in lead 1 and also in AVF. So the net deflection will be in second quadrant, it will be a normal QRS axis. And we discussed when this is negative, this is positive, it is in the right axis, so on and so forth. The axis gives us the direction of depolarization. In cases when there is pacing, the pacing, the direction of the impulse can also tell us in which direction the pacing is occurred and from which chamber it is happening. For example, the RV outflow tract pacing happens in the normal axis. The RV apical pacing leads to impulse in the left axis. The biventricular pacing happens when the axis in the extreme northwest axis, and the LV pacing leads to impulse transmission to the right side, leading to the right axis deviation. These things are complex, but this is just the basic impulse transmission, the direction of impulse transmission leading to the determination of the axis, basically. So we saw that causes of northwest axis is VT, hyperkalemia, paced rhythms, some of the paced rhythms, and COPD when there is cor pulmonale leading to RVH. In some cases, when there is dilated RV, we can have extreme axis. In right axis, we have already enumerated these causes. Coming to the P wave after the axis determination, and also in some cases, the positive and the negative deflection of the QRS complexes are nullified by each other, and you get a net 0-degree axis, in which cases the axis becomes indeterminate. So that is one additional point. The P wave represents atrial depolarization. Usually, the height of the P wave should be less than 2.5 millimeter, and the length should be less than 0.12 seconds. There are absent P waves in cases of atrial fibrillation, AV junctional rhythm, or SA node block, because either the impulse generation is down from the SA node, from the atria, or the AV node, or the ventricle, or there is exit block from the SA node, which leads to absent P waves. If the length of the P wave is more than 1.12 seconds, leading to a notched P wave or a widened P wave, it is P mitral. It is due to left atrial overload. Usual causes are mitral valve disease, left ventricular hypertrophy, cardiomyopathy, systemic hypertension, which is mainly because of the dilated or overloaded left atria. Likewise, if the height is more than 2.5 millimeter, it is P pulmonale, which is a peaked P, which is due to right atrial overload uh, because of pulmonary hypertension, pulmonary stenosis, tricuspid stenosis, right ventricular hypertrophy. The PR interval, the normal PR interval is usually between 0.1 to 2.20 seconds. The PR segment represents time taken by an impulse to travel from AV node through a bundle of hairs to the ventricles. The main interest in PR interval is because of the various AV blocks. The first degree AV block is denoted by a constant PR interval, which is more than 0.20 seconds. And each P wave is followed by a QRS complex. In second degree type 1 Wenke-Bach's phenomena, the PR gets prolonged subsequently, gradually over subsequent periods until the QRS complex is dropped, which is type 1 Mobitz. When PR is constant and every and then a QRS is dropped after a fixed number of P waves, it is second degree type 2 Mobitz. And when there is complete AV dissociation. There is no discernible relationship between P waves and QRS complexes, and there is a complete heart block. It is a third degree AV block. We will be discussing it with the diagram in the next slide. The causes of prolonged PR are AV blocks, degenerative conduction defects, and the shorter PR occurs in WPW syndrome because of the accessory pathway, the Laon-Galong-Levine syndrome, glycogen storage disease, and Fabry's disease. Here, it is a normal sinus rhythm. Each regular P wave with a normal PR interval is followed by a QRS complex. In a first degree AV block, the PR is prolonged, but each P wave is followed by a QRS complex. In second degree, there is subsequent prolongation of the PR interval leading to a dropping of the QRS complex in the end. And when the interval between the PR interval is constant, but then after every subsequent fixed number of P waves, there is a dropping of the QRS complex in the way of a fixed 2:1 or a 3:1 uh, second degree type 2 Mobitz heart block. When there is total AV dissociation, the atria and the ventricular beat independently of the each other. It is a third degree or the complete heart block. The Q waves, usually Q waves are present, but what is of interest is a pathological Q wave. If the Q wave is more deeper, but more than by 0.2 millivolts, which is two small squares, or wider than 0.04 second, that is a one small square, or if the Q wave amplitude is more than 25% of the R wave amplitude, or it is present in two contiguous leads. Contiguous leads are depicting the same side of the myocardium, like lead 2 and AVF, or 1 and AVL, or V1 and V2. Then it is a pathological Q wave. It is a marker of previous MI. QRS complexes. The QRS complex represents rapid ventricular depolarization, and it's widened by delay in intraventricular conduction system and ventricular hypertrophy. Uh, if the complex in the chest leads look tall, one has to consider LVH. Uh, uh, there are different criteria to know whether LVH is there or not. If the depth of the S wave in V1 added to the height of the R wave in V6 is more than 35 millimeters, there is more likelihood of LVH. And if R wave is usually R is smaller than S in V1, V2. But if RS ratio is more than 1, it is suggestive of right ventricular hypertrophy. There are different uh, ways in which QRS complexes may occur. If the first wave is only a positive wave, it is a R wave. There are no Q, there are no S. If a normal large R wave is followed by a smaller S wave, then we, for the sake of reporting, we say it is capital R and small s. If the R wave is smaller than the S, then we write smaller R, capital S. If the Q wave is smaller, normal R, smaller S, then it is a smaller QRS complex. If Q and R are equal in amplitude, then we write QR capital. When there is no R wave, it is only a negative deflection, then it is a QS complex. Likewise, when there is a pathological Q with a small r, then it is a QR without any S. If there are two R's, rabbit ear QRS complex that we see in RBB pattern, then the first complex is a small r, small s, then a second complex that is the R complex is the larger one is the capital one, and the second complex is prime. So small r, first small r complex, then a smaller s complex, then a larger r. But since it is a second r, it is a r prime. It can happen that the second r can be a smaller one than the first. Then the first will be capital R, and the second R will be a smaller r but prime. So it is just for the sake of annotation and reporting in the ECG, so that the reporting is standardized. QRS width normally is should be less than 0.12 seconds. That is three small squares. If the QRS is wider than this, it's just a ventricular conduction defect, usually the right or the left bundle branch blocks. When we are assessing a QRS complex, we need to ask ourselves questions: are criteria for RBB or LBB met? Are there pacemaker spikes seen? Are there delta waves visible, or there is a poor R wave progression? Because all the questions have specific significance. If there is a mnemonic EKG mnemonic for RBB and LBB, William Morrow or William Marrow. So if W in V1 and M in V6 is seen, it is in LBB. So W in V1, W of William, LL left bundle branch, and M in V6, William, Morrow or Marrow, double R for RBB, M in V1 and W in V6. It is a RBB pattern. The pacemaker spikes are linear vertical spikes before QRS complex or P waves, depicting pacing from a pacemaker. Depending upon whether it is a ventricular pace or an atrial pace or dual chamber pace rhythm, we will get pacemaker spikes. Delta waves are visible in accessory pathway, like in Wolff Parkinson White syndrome. There is accessory pathway which leads to ventricular depolarization, which results in a slurred upstroke of the QRS complex, resulting in delta waves. There, the PR interval is also shortened, less than 0.12 seconds, and QRS complex is widened. So basically, broadly speaking, QRS complex abnormalities are broad QRS complexes seen in LBB, RBB, VT, hyperkalemia, tall QRS in LVH, RVH, poor RV progression in anterior wall MI, LVH, left bundle branch block, or Wolff Parkinson White, mainly type B, and dominant R. Usually the R waves are smaller in V1 chest leads, but if it is more than S wave in V1, then it has significance that it might be because of RBP, RVH, type A, WPW, posterior wall MI, in which we get dominant R in V1, V2 with ST segment sagging in the same leads, depicting ischemia of the posterior wall. And it is usually seen in children because they have a dominant right-sided circulation. The ST segment usually should be isoelectric. The ST segment should be in line with the PR segment. But any planar elevation or depression of the ST segment is abnormal. Planar ST elevation represents MI, transmitted angina, or pericarditis, and ST depression represents ischemia. Myocardial infarction, localization of the myocardial walls, depending upon the changes which lead has these changes, will help in the uh, areas of MI in which it is localization, which further helps in the localization of the culprit vessel also. As you read 2, 3, and AVF, they are usually depicting the inferior surface of the heart. So if there is STT changes in 2, 3 AVF, it denotes inferior wall MI. If V1 and V4 show planar ST elevation depression, it is usually in the anterior wall. If it is between V4, V6, and 1 AVL, then it is the left lateral wall. And if there is dominant R wave with ST in V1, V2, it is usually the posterior wall. And especially it's like V7, V8, V9 posteriorly in the left side. The ST segment elevation can also help in finding out posterior wall ischemia. Here we see uh, physiological ST depressions. If there is an upsloping ST segment depression, it is usually normal during physical exercises or exercise stress testing. it should be considered normal finding provided that T waves are not inverted. Hyperventilation may also cause similar ST segment depressions. There are non-specific ST segment depressions which occur in hypokalemia, high sympathetic tone, and basically uh, happens at higher heart rates. Some drugs like digoxin cause scooping depressions in the ST segment, and they are usually known as a digitalis effect or digoxin effect. ST segment depressions causing uh, uh, cause acute or a downsloping one. With an upsloping ST segment depression, there is one exception where it can also occur, and it is quite significant. Is it in the D winter sign, where in V1 to V6 there is a upsloping ST segment depression followed by a tall T wave. It usually occurs in a proximal LED artery occlusion, leading to anterior wall MI. So this is one exception to our sloping ST segment depression. Considering my ST segment, always you have to understand that deviation in the ST segment always indicates ongoing that indicates acute ischemia. Uh, there are two types of acute coronary syndromes: the non-ST elevation or the ST elevation. The non-ST elevation MI is usually the subendocardial ischemia, where the uh, epicardial myocardium basically is not affected. There is only subendocardial ischemia where the ST segment vector is inwardly drawn, which leads to the downward sloping of the ST segment. This happens in anastomy or unstable angina, where ongoing subendocardial ischemia is there, and the T vector is also inwardly drawn, leading to T wave inversions. In ST segment elevation MI, usually there is a transmural ischemia, and the usual current of injury from inside to outside leads to the ST segment elevation. And the hyperacute T waves also occur because of the repolarization anomalies. The hyperacute T waves only persist for a few minutes or hours, where after the J point becomes elevated. This also happens in the D winters ECG that we discussed earlier. Uh, this is a typical ECG of an acute anterolateral MI. Here, you can see that there is ST segment elevation in one AVL and V2 to V6. The changes are more prominent in V2 to V4, but it is also present in V5, V6 also. So the anterior walls V2, V3, V4, and the lateral V5, V6, 1 and AVL. They depict the total ischemia in the anterior and the lateral walls. In inferior walls, the leads involved are the 2, 3, and AVF. Here you can see the ST segment elevation with pathological Q waves in the inferior leads. Most, in some cases, inferior wall MI is also associated with posterior wall MI because the of the culprit vessel, the right coronary artery, where you can see a dominant R in V2 and ST segment sagging, not elevation, which is a reciprocal change in the posterior wall, depicting anteriorly as ST segment depression. And sometimes inferior lateral leads might be involved because of the left circumflex supplying the lateral and the inferior walls. So, depending upon the culprit vessel and the area of the myocardium involved, the changes will occur. Because that will lead to the impulse traveling in that particular direction, the current of injury in the inferior or the lateral or the anterior walls. The axis also changes subsequently. Appearance of Q waves does not mean that it is an evolved MI. Uh, if such patients present to us, we should go ahead depending upon the duration of the symptoms and thrombolysis. This is a typical ECG of a non-ST elevation myocardial infarction depicting subendocardial ischemia, where deep symmetrical T wave inversions are there with minimal ST sagging if you compare it with the PR segment. So these NSTEMIs usually denote proximal LED regions. Pericarditis, ECGs with acute pericarditis mimics ST elevation, but there are certain subtle differences. Usually, ST elevations less than 5 millimeter occur in pericarditis. There is no localization of a vessel territory. There are no reciprocal changes which occurs in ECGs with pericarditis. For example, if we're in an ST elevation MI of the inferior wall, you might see reciprocal changes in the lateral wall, in the high lateral wall, or vice versa. If you see sometimes the lateral wall MI are difficult to catch on V1 AVL and V1 or V6, sorry. So we only get to see the reciprocal changes in lead 2-3 AVF, and they denote ongoing ischemia in the lateral wall. So these reciprocal changes don't occur in pericarditis. It is a totally whole and whole ST segment elevation, which is subtle, less than 5 millimeter, with changes in the PR segment as well. And later on in stage 3 and 4, T wave inversions may also happen when there is associated myocarditis along with pericarditis. Uh, T waves generally shouldn't be taller than half the size of the preceding QRS complex. But if they are taller than that, we need to consider the most common possibility is hyperkalemia or hyperacute MI, where there may be tall T waves. The typical ECG appearance of the tall T waves, there are peaked T with prolonged PR when there is mild hyperkalemia. There is loss of P wave with prolonged QRX with ST segment elevation and frequent ectopics or escape rhythms in moderate hyperkalemia, and in severe hyperkalemia, it may degenerate into a sine wave rhythm or VF or cardiac standstill in the form of asystole. The normal T waves can be smooth transition from ST segment to T wave. The T wave is slightly asymmetric with a steeper downslope. Uh, in hyperkalemia, it is large, symmetric, pointed with a shorter base. The hyperacute T wave in transmural ischemia are usually high but broader base and symmetric, not pointed, almost always seen in conjunction with ST segment elevation. The biphasic T waves have both positive and terminal negative deflection, and these are usually seen when the MI is evolved during the evolution of the myocardial ischemia. Post ischemic T waves are shown in the first figure. They are usually symmetric T wave with varying depth, ranges from flat T wave to very deep T wave inversion. Inverted T waves do not equate to acute ischemia, but rather appear after an episode of ischemia when the ischemia has evolved. The ongoing ischemia, the T wave inversion with simultaneous ST segment deviation, most commonly depression. Note that it is the ST segment deviation that represents acute ischemia. In cerebrovascular accidents, usually in intracerebral bleeds, we can see T wave inversions, which are usually very deep. They occur. It is hypothesized that it occurs because of catecholaminergic surge that occurs with intracerebral hemorrhage. In hypertrophic cardiomyopathy, symmetric T wave inversions most commonly in V1 to V3, often very deep and accompanied with large R waves, occasionally accompanied by ST segment depression, and there is loss of a routine R wave progression in hypertrophic cardiomyopathy as well. In perimyocarditis, the T wave inversions occur after normalization of ST segment elevations, and T wave inversions often seen. They are seen in almost all the leads, as we discussed earlier. In hypokalemia, usually there is uh, these are ECG changes that occur with electrolyte disturbances. As we discussed, these are important to know because if you are suspecting somebody to be having an electrolyte imbalance, you send blood samples or serum samples to know the exact levels. But if there is uh, ECG changes pertaining to a particular electrolyte imbalance, you should not be wasting time and go ahead and correct the imbalance, because they might be life threatening and you won't be able to wait pending the results of the blood test. So and vice versa also, if you have the results with you and there are no ECG changes of the particular electrolyte imbalance, then you should be wary of treating it and double check it with a repeat sample, because at the end of the day, these electrolytes causing neurological deficits or toxicity. So cardiac balance is very important to know. In hypokalemia, usually there is ST segment depression with flattened or inverted T waves, and there is appearance of the U wave also. They vary with the severity of and the grades of hypokalemia. In hyperkalemia, as we discussed earlier, mild, moderate, severe, there could be flat P wave, prolonged PR, QRS widening, and tall P waves degenerating into a sine wave rhythm or VF. In hypocalcemia, there is prolonged ST segment with prolonged QT interval. In hypercalcemia, there is shorter ST segment with widened T wave. In hypomagnesemia, there are usually tall T waves with ST segment depression. In hypermagnesemia, there is prolonged PR interval and QRS widening that is associated. So, with these changes, we should predict these particular electrolyte imbalances that we have discussed, confirm it, and treat it. And if it is an emergency, I would suggest treat it even before you get the blood results, uh, depending upon the clinical condition of the patient. Most of the things that we have discussed here, uh, the interpretation of an ECG becomes purely mechanical if it is not backed up by a strong clinical data, because you interpret the ECG in the light of the clinical status, the clinical condition of the patient. These changes will not have much meaning and is purely mechanical exercise if we don't know the background in which we are interpreting the ECG. The QT intervals, the normal QT interval is 0.35 to 0.45 in males and 0.36 to 0.46 in females. The short QT intervals are found in hypercalcemia. The long QT are usually seen in hypocalcemia and long QT syndromes that we have discussed earlier. These things are, these QT intervals are, they hold true with a normal range heart rate with 60 to 100. If the heart rate increases or decreases, then you might uh, uh, think it to be a false shorter or false higher QT intervals. For that, we need to see a corrected QT interval in the form of QTC, for which the usual formula that we use is a Bezet's formula, which is a QT interval divided by square root of the RR interval. That gives you a corrected QT interval that incorporates the length of the cardiac cycle also. It takes into consideration of that particular aspect and gives you a actual QT interval that you should see. For a rough calculation, if the QT interval is more than half of the RR interval, you can take that it is a prolonged QT, but that is a rough estimation. You have to calculate it properly on the ECG graph. U wave, prominent U waves appearing after T waves are signs of hypokalemia or hyperthyroidism. Causes of long QT interval, because it predisposes to so many malignant arrhythmias, for example, VT, VF, tositis, key point is. A lot of medications are there which cause long QT, like diuretics because of electrolyte imbalances, antiemetics like ondansetron, antipsychotics, tricyclic antidepressants, which usually cause sodium channel inhibition, leading to QRS widening as well as QT prolongation. Selective serotonin reuptake inhibitors, antiarrhythmics, anti-angina drugs like ranolazine, anti-infective drugs like macrolides, fluoroquinolones, antifungals, mainly antifungals. Metabolic disorders like anomalies of potassium, magnesium, and calcium that we discussed, starvation, hypothyroidism, bradyarrhythmias like sinus node dysfunction or AV blocks, and miscellaneous conditions like hypothermia, MI, intracranial disease, and HIV infection. Supraventricular tachycardia, it is when the electrical impulse generates above the heart's ventricle, but not from the SA node. Below the SA node, but above from the AV node. A normal heart beats 60 to 100 beats per minute, but when you have an SVT, your heart may be sustained way above 100 beats, sometimes up to 180 or 200 beats per minute for several minutes or hour. You may feel that you have a racing heartbeat, which can be described as palpitations. Single lead electrocardiogram showing rapid regular heart rate from a supraventricular tachycardia, which is a narrow QRS complex tachycardia. Uh, it could be AV re-entrant tachycardia, in which you might get inverted P waves also. Atrial fibrillation or flutter is also a type of a supraventricular tachycardia. When you get an irregular heart RR intervals, then it is atrial fibrillation. If they are regular, then it is a flutter with a fixed AV block. If there is a variable AV block with flutter, then you might also get a irregular RR interval. So, but the differentiating point here is the appearance of a P wave as sawtooth pattern in flutter, and total absence or just a vague electrical undulation of the isoelectric line in the preceding the QRS complex in atrial fibrillation. You are not able to, you will not be able to identify typical P waves in atrial fibrillation. In ventricular tachycardia, the impulse generation is from the ventricles. The QRS complex is wide, and they are basically two significant findings that we see in the ventricular tachycardia is fusion beat and capture beats. I won't be going into the Brugada's criteria today itself, because that will make the matters more complicated. It will be we can take it at a later date. The fusion beats are basically an hybrid beat between a normally conducted QRS complex from the sinus node and the ventricular beat. And the capture beat is when we capture the sinus rhythm generated from a SA node traversing through the AV node to the ventricles in between an ongoing ventricular rhythm. So if you are able to see a fusion beat or a capture beat, then in between a wide complex tachycardia, then there is no doubt it is a ventricular tachycardia. Usual types and etiologies are monomorphic, polymorphic, or slow sinusoidal VT. Monomorphic VT occurs in usually they are idiopathic or scar related or Purkinje fiber related. Polymorphic are VT is usually seen in acute MI, ventricular scar, hypertrophy, failure, or some genetic sudden death syndromes like long QT, short QT, Brugada's, or catecholaminergic polymorphic VT syndromes. Or the slow sinusoidal VT are usually seen with hyperkalemic, drug toxicities, and end stage heart disease. These are the different examples of VT and VFib. This is a Torsades D pointis that is predisposed by a long QT, in which there is a twisting around a point. It is a sort of a polymorphic VT in which the QRS complexes are twisting around a point, uh, uh, depicting in the form of a larger and the smaller QRS complexes. VFib is just undulating ECG line. You don't see QRS complexes there. One important drug that is of a particular interest for ECG interpreters is digoxin. Um, Digoxin effect, digoxin toxicity, digoxin related arrhythmias. They are very interesting and important for any ECG interpreter. virtually any arrhythmia is possible with digoxin toxicity, but none is very specific for the toxicity. Except for the Venki-Bax phenomena, all the arrhythmias can happen, and two arrhythmias which have slight specificity for digoxin can be uh, paroxysmal atrial tachycardia with variable AV block and bidirectional junctional tachycardia that are usually very strongly associated with digoxin toxicity only and not with anything else. Classic arrhythmias thought to be associated combine some SVT with slow ventricular rate. Digitalis effect is usually depicted in the form of shortening of the QT interval, scoop or sagging segment depressions, J point depression, and flattened, inverted, or biphasic T waves. Uh, I think these are the usual commonly seen ECG anomalies that I think we should take up as an exercise in our free time and maybe in a subsequent lecture also. And when we are more comfortable with our knowledge of ECG interpretation, uh, that will help us in honing the skills of the interpretation of the ECG. Uh, Thank you so much. That is all for today.
Thank you so much, Dr. Amit. That was really a marvelous effort, as completing an ECG class in 1 hour is really next to impossible. Now I would request the audience to put in their questions in the chat box if they have any.
So all the module sir will address that. Okay. Only me question. And we have to answer. You have to leave the chat. Okay. So there are no questions, Dr. Mudit?
Sir, as of now, none. So I think we'll wait for a minute or so. Sir, I have a question regarding, say, because most of us usually practice in the wellness centers.
Yes.
Say, what are the uses of ECGs in outpatient basis, not as a case of emergencies? Say, to monitor what all conditions can you think of?
Look, there are so many things that we can think of here. For example, if somebody is coming with a complaint of shortness of breath, a simple ECG can tell you what could be the underlying pathophysiology. Suppose you get a RVH, right axis deviation, features of cor pulmonale. Uh, that can help you in knowing that yes, it is less likely to be of a primarily cardiomyopathy, cardiac origin, but a cor pulmonale secondary to pulmonary disease. On the other hand, if you are able to see a LBB or a widened QRS complexes, bifascicular blocks, uh, atrial enlargements in the form of P mitral, then you can think it could be a congestive cardiomyopathy and needs to be decongested there. For so in defining the therapy, although it is not a very foolproof, it still is a very crude method. But in my practice, I find it to be very useful in on more occasions than none. So you get a preliminary idea if the physical signs are not very indicative of a particular thing, then ECG guides you even before chest X-rays and everything or echo reports, what you should be thinking about and whether you need to give bronchodilators primarily, oxygen supplementation or diuretics. Uh, for a particular patient, for example, coming with complaints of breathlessness, and somebody coming with a swollen limb with breathlessness, showing particular ECG findings of a right axis deviation or an S1Q3T3 pattern, which is not very commonly seen in, which is only seen in 10% of pulmonary embolism cases. But unexplained sinus tachycardia or right axis deviation in somebody with a swollen limb and with sudden onset breathlessness without any chest pain might indicate pulmonary embolism as well. So there are so many things that
Definitely,
correlate.
sir. Definitely. Uh, so I don't think any questions are there. Uh, a lot of people have joined us today. Nearly, I could see maximum of 175 people joined us at the peak of the presentation. Thank you so much for the presentation, sir.
Thank you so much. I hope that it was of some use, because uh, compressing so much information in a 45-minute, 50-minute class, I don't think it does any justice to the listeners, but at least it gives some impetus to go further and take an ECG textbook and go through it and search on the internet, finding further information on the basis of these fundamentals and honing your skills in the interpretation of the ECG. That might be helped by this class today. So thank you, Dr.
Definitely,
Mudli.
sir. Thank you, sir. Thank you so much.
Thank you.